So good afternoon and welcome to Business as Usual. This is Audrey Russo, President and CEO of the Pittsburgh Technology Council. I'm very thrilled by today's guest. Very honored to have our guest, who I'm going to introduce in one moment. She is Senior Director, Infection Prevention at Johns Hopkins University. So the topic is near and dear to all of us. And I'm also joined by Jonathan Kirstang, who's Vice President of Visibility and all things media on our team. So I do want to give a shout out to Huntington Bank. Huntington Bank has been a sponsor since we started this series, oh gosh, what, 15, 16 weeks ago? Hard to believe that we're doing this every single day, but every day we continue to get amazing guests and continue to have really important conversations that are affecting each and every one of us. So on that note, I just want to remind everyone that we've muted your microphones to make sure that any noise in the background is eliminated. And we also have a chat. So the chat will allow opportunities for you to ask questions of our guests. And, you know, we will see what we can do in terms of navigating all the questions that will come up. So I am very, very thrilled to introduce what's happening to our screen right now. Does everyone see the screen? Okay, good. I'm happy to introduce Dr. Lisa Maragakis, and she is, as I mentioned before, she is at Johns Hopkins. And before we start and sort of dive into some of the questions here, I'd like to, first of all, welcome Dr. Maragakis to the show, and thank you for taking the time with us. But just tell us a little bit about your professional background so people can understand exactly why we're so thrilled to have you here and the capabilities and perspective that you're going to bring to all of this. So welcome.
Thank you so much, Audrey. I really appreciate the invitation. I'm so happy to be here, and I'm really looking forward to the conversation and to addressing everyone's questions about COVID-19. I am a faculty member here at Johns Hopkins University. I'm an infectious disease physician, adult infectious disease and internal medicine. I came to Johns Hopkins over 20 years ago to go to medical school and have stayed in Baltimore and at Hopkins since that time. My area of specialty is infection prevention, and specifically the prevention of healthcare associated infections. And I do this for our hospital and for our entire health system. Before the pandemic came along, I was responsible for policies and procedures and interventions to really protect all of our patients from healthcare associated infections. And of course, outbreak investigation, epidemiology, and infection prevention are very critical now that the pandemic is here. So
yes,
thanks again for inviting me.
No, absolutely. Thank you. Thank you for setting that up. So let me just start with, from the outset of the current pandemic, Johns Hopkins was actually thrust into the international limelight for millions of people for looking for data. You know, really hard to try to find the data, what's the good source of data, real-time data, et cetera, on COVID-19. So what I'd love for you to do is talk about the capabilities of Johns Hopkins, and that has uniquely positioned the institution to really provide leadership during this type of global pandemic, and not just for the United States and for all the different states and regions, but also for the globe.
Right, it's such a good question. And, you know, I do think Johns Hopkins is an amazing place. It's part of the reason that I feel privileged to work here, and then that I've stayed here as a faculty member. We have amazing people who have research interests and clinical specialties in so many different areas. Our infectious disease department specifically, of course, is front and center in the pandemic response. And we have an extremely strong and diverse faculty in infectious diseases. More specifically to your question with regards to leadership, you know, I think we have been able as an institution to play a role, particularly in providing data. when it is so desperately needed, and is really the currency by which we can measure our progress, both the spread, the transmission of the virus, its effect on populations, really being able to drill down worldwide to see the differential effects on different populations, as well as other important metrics, including the extent of testing, the mortality rate, and other metrics. So that's just a flavor of some of the capabilities here. And I do think that Dr. Lauren Gardner and her team, who put together the Johns Hopkins dashboard, the data dashboard that has been so prominent during this crisis, is just really a jewel that we have been able to provide. And we all rely on it. I think people really around the globe are relying on it for accurate, timely data. And then I guess another thing I would mention is just our experience in handling infectious diseases and high consequence pathogens. So here at Johns Hopkins, we do have a biocontainment unit that was founded during the West African Ebola crisis in 2014. And at that time, we really made a strategic decision to designate part of our Johns Hopkins Hospital for the care of patients with highly infectious diseases, and to train a team to be prepared for expert use of personal protective equipment and policies and procedures in that space to keep everyone safe. And so, as you can imagine, you know, Ebola certainly brings out fear in everyone, and so all of that preparation really served us well as we confronted the pandemic.
It'd be interesting to know how many visitors are actually on that site every day. I can imagine from a technology standpoint, it's always up, it's always working, and there have to be millions and millions of visitors that are using that site. That's very dynamic, that you're able to slice and dice and sort. So you are the go-to place for that. So let's talk about it. As you know, in early March, you actually briefed members of Congress on the adequacy of testing and argued that efforts, at least back then, were not sufficient. So talk about the availability and reliability of tests that have evolved over this time. We say time, it seems like a long time, but it hasn't been. And do you see improvements in antibody testing, for example? And that, are we ready for potential second wave? And what does second wave mean? So I've chunked out a few things in that question. So if you want me to repeat that, or if you can just take a stab at it, that would be terrific.
Sure. Well, there's a lot to unpack there. Specifically with regards to the testing, I think everyone is aware that we really were very slow off the mark in the United States to have the availability of reliable testing. And just to be clear, when we're talking about that type of test, it's a PCR, polymerase chain reaction. That's a direct detection of the virus in the back of the nose or throat. And this is the kind of testing that really has been so important around the world. It's one of the bread and butter tools that we have to identify patients who are infected with the virus and be able to take steps to isolate them and prevent further onward transmission. Unfortunately, we did not have adequate testing at the beginning. Both the types of tests that were available had problems. Initially, all of the tests went to the CDC and had a very long turnaround time, which defeats the purpose of quick identification and isolation. We were very fortunate here at Johns Hopkins that our pathology colleagues developed an in-house test, and many academic medical centers, I think, had the advantage of being able to do that. And so those were some of the first and only tests that were available for a while, even before states got reliable ability to test. And then even once the tests started to become available, we have suffered intense supply chain disruptions for the reagents for the test, and even simple things like the swabs to collect the samples. So it's really been a challenge for a long time. Very frustrating. Our own lab validated 8 different platforms in order to make a patchwork together to provide the capacity that was needed for our own patients here at Johns Hopkins throughout our health system, and then to be able to augment for the entire Baltimore region and provide testing to other healthcare facilities and the community at large. So I think it's still uneven across the country. There's still a great need, particularly to improve access of vulnerable populations and people who really need access to testing. You mentioned the serology test.
Right.
So the one good thing about the PCR test is at least it's very sensitive. Once you can get your hands on it, it's very sensitive, and essentially all the different types are fairly equivalent. Now we've had progress so that some of them have a turnaround time that's much faster, so you can get an answer in minutes rather than days. Usually though, it'll take hours before a typical lab will be able to give you an answer. And then the serology test, on the other hand, so that's the test that's a blood test looking for antibodies. There's a few things to say about that. Number one, there's a lot of different kinds, and they are, in contrast to the PCR, they're very variable. So it really matters which kind of serology test a lab is using. Some are more reliable than others. Some are looking for different types of antibodies. There is a concern, and this is part of the variability, is that there's a concern about cross-reaction. So if you detect an antibody, is that specific for this novel coronavirus, or could it be a reaction that shows that the person had a different coronavirus with a common cold or something else? So we still have a ways to go with the serology. Honestly, the serology is not that useful clinically because it takes a couple of weeks before a person's immune system kicks in to have enough detectable antibodies. So really, in the throes of illness, you want that PCR test. The antibody test can be helpful if somebody really has symptoms that seem like COVID-19, but the PCR test for whatever reason is negative. Then we can check and see if they have evidence of antibodies. But other than that, it's primarily a research tool right now.
So what about the supply chain? Let's just dig on that a little bit. You said, is it still uneven? Are there still issues in terms of the supply chain? I mean, you're talking about swabs. That was one example, but I'm sure there's many others. How is that now?
It is a problem still. It depends on what you're talking about. So for the reagents and the swabs, there are still limited quantities. It seems to have eased somewhat. But of course, the supply chain disruptions are really across the board. And it's one of the most surprising things to me about being in this position and trying to respond to such an enormous infectious disease threat, and finding supply chain limitations for our personal protective equipment, for our even simple things like hand sanitizer and disinfectant. And so we have really struggled. We are still, and when I say we, I mean healthcare collectively. So at Johns Hopkins, we have been creative, very innovative. We've made a lot of homemade solutions. We have partnered with manufacturing and community partners and volunteers in a lot of cases to come up with innovative solutions, but it's been a challenge that's ongoing.
Yeah. Okay. Well, that's good for us to know. And before we get to questions, I wanna ask you something about, time has progressed, even though it's only been 16 weeks or whatever for all of us. It seems almost like a lifetime. We've learned more, you've learned more about COVID-19. What has surprised you about the changes in the pandemic?
So in addition to the supply chain, which was one of the biggest surprises, I think the other thing that is surprising and unfortunate is just the complexity of this illness. And so as if it's not bad enough to have a respiratory virus sweeping through and causing, in some cases, very severe and unfortunately, in many cases, fatal pulmonary disease. So respiratory failure, needing ventilation. There are so many other health effects of this virus that we continue to discover. And it really raises even more questions. And it's not as straightforward as one would hope of supporting someone through that pneumonia and respiratory illness. So I'm sure many people have heard about the other health effects, and we're discovering new ones, it seems, each day, but there are neurologic effects, clotting disorders, effects on the kidneys, on the heart, a much wider age range affected. So we're learning more about the effects in children and the inflammatory syndrome that can sometimes be quite severe and even fatal for children. So I think, and now the most recent questions that we are really examining have to do with the duration of viral shedding. So people whose symptoms improve, but they continue to test positive for a number of weeks, and really trying to answer the question of what does that mean? Some of them tend to relapse and have new symptoms. And so we wonder how infectious those patients are to other people, right. And really what that means. So there's many research studies ongoing and many questions that are unfolding, but it's a complex virus, and people's response to it is quite complex.
Well, yeah, and there's no way that I'm going to do any favors in terms of the complexity of all of this, but I think one of the things that we're hearing news, media, everything's changed. Anecdotally, doctors are saying, and again, you can correct me on this, that the virus appears to be weakening, right, to some extent, and perhaps becoming less lethal, et cetera. Is there evidence to even back that up? Is there evidence for that conversation, or is it more about what you just said before, that it's becoming more complex and we actually know less?
So, I think that there have been a lot of questions about the fact that, well, let's take the United States data right now. Our cases are surging. We are seeing about a 40% increase over the last several weeks in our daily case counts, or our average daily case counts, and yet the death rate is falling. So this may be fueling some of those discussions about whether the virus is changing, and those changes are responsible for the lower mortality rate. I would argue that is less likely to be the case. There are analyses that are ongoing looking very carefully for mutations in the virus, and to date we haven't seen a large change in the virus itself. You can use genetic analysis to track the virus, and some of that has been reported so that you can kind of see geographic areas that have led to introduction of cases into different areas. But those are very small changes and not really something that we would say is affecting the clinical outcomes. Mm-hmm. What I think is more likely is that as the virus sweeps through populations, the most vulnerable do die, unfortunately. And now we are seeing kind of second and third waves of, I use that term separately from like the epidemiologic waves, but of groups of people that are younger, maybe have fewer comorbidities, and are surviving the disease, thankfully, at higher rates. So the mortality rate,
it's ever changing.
I don't think it's right.
Right. And so, yeah, I mean, I apologize if I was trying to be simplistic on it. I know that you're doing an incredible amount of research, but people like to boil things down into an answer, and I get that. We do have a lot of questions. I just want to ask one more thing, though, before we jump into a few questions and then get back. So in a recent ABC News piece, you actually talked about mask wearing as really being part of our social contract with each other. And I love that. I love that you're talking about this social contract in terms of mutual respect. And, you know, some people are skeptical. They're still skeptical about mask wearing. We see that in, you know, many places. It's not just Pittsburgh, it's all around the United States. So with companies heading back to work, you know, in terms of, you know, whatever that means, back to work, you know, that's another lengthy conversation. But as people start opening and we move into, in our region, what we're calling green, talk about the effectiveness and the combination of mask wearing, hand washing, and social distancing in terms of prevention.
Sure. So those things, those three elements are the fundamental basic infection prevention tools that we have to fight this virus. And the way that I look at it, that is really all that we have. And yet they are very powerful, but they need to be used in combination so that we are really attacking the transmission chain of the virus person to person. So we go back to the science and know that this is a respiratory virus that is spread through respiratory droplets. That can be through coughing and sneezing, which is what we've always emphasized for respiratory virus transmission. But what we now know from the science too is that those smaller droplets that we all know are associated sometimes with loud talking or screaming or singing can also transmit the virus. And so that's the purpose of the mask. I think we all recognize that it has been politicized and that it is also a major behavior change. Right. It is something that in a very short time we have asked people to do that is unfamiliar. It's not part of our culture. Quite frankly, it can be uncomfortable and hot, and it interferes with facial expression and communication. So there's a lot of things not to like about it, but really the masks are a physical barrier that contains respiratory droplets. And that's why I talked about the social contract, because I do feel that when we see a lot of reports of people refusing to wear a mask or being cavalier in their choice to not wear a mask, they may think that they don't care about themselves, but it's really that when you wear a mask, you're protecting the people around you. And that's why it's a social contract, that if we all would do this, we would protect each other.
Mm-hmm. Right. That's very eloquent. So we have like a whole bunch of questions here. So Jonathan, and I want to be able to get to that. And, you know, we'll run a little bit longer because some of the questions are just
good ones.
Terrific.
Absolutely.
And if that's okay. So I really would love to, Jonathan, can you see from the top?
I can see them all pretty much. Okay, yeah,
so
let's start there.
Can we do some rapid fire?
Give you some rapid fire.
Right.
So first and foremost, any thoughts on how South Korea's testing was so much more effective than our testing?
Yeah, so there are countries, South Korea and Germany, I think are two of the best examples that really did a fantastic job of implementing widespread testing. They did it early, they did it at scale, and really used the answers of the tests to take action. To isolate and quarantine people who were affected, to follow that up by notifying and tracing the contacts. And so that's that search and destroy strategy. Mm-hmm. But it needs to be done at scale, it needs to be done rapidly, and really widespread availability. And we've struggled to do that.
Absolutely. So here's a 2-for-1 question. You can probably knock this out with one answer. Yeah. The idea of going back to school, whether it's young kids or going back to college campuses and wearing masks and just getting back there in general. What are your thoughts on that?
Oh, that's a huge topic, and there's no easy answer. We've certainly been talking with a lot of schools and with our own university about this as well. I guess one thing that I would say is that, you know, I do think that it is possible to resume some normal activities using the interventions that we just discussed, environmental cleaning, hand hygiene, social distancing, and wearing masks. It takes a huge behavior change, as we discussed obsessed with the mask wearing. So does social distancing. We just are drawn to each other, and it's really hard to change those behaviors and stay away from each other, separate chairs, and redesign the way we interact in our space, and sometimes the spaces themselves, to make it easy to do the right thing. So it's going to be a huge challenge actually for schools for a variety of reasons. You know, it's hard enough for us to change our behavior. You know, children, I think, of varying ages will have different abilities to understand why that's necessary or to comply. There's you know, it's harder, I think, with children because we're not seeing, well, now we are seeing the inflammatory syndrome, but we're not seeing as widespread symptomatic disease. But of course, those children can take the virus home to their families and to people who are more vulnerable. So I'm very cautious and worried actually about schools reopening, and even college campuses, because of the dorm living situation, I think have a lot of challenges.
There are two questions, Jonathan. Can you ask Rich Lunak's question and Michael Nilo's?
You were reading my mind. Let's start with Rich real quick. He said, recently Johns Hopkins published data comparing the number of new cases between the EU and the United States. The data showed that the European Union had a significant drop in new cases since March and has maintained that lower level. However, the US has not really seen that distinct drop. What are your thoughts on that, and what could be causing this difference that they're getting lower and we're getting higher?
Yes, I've seen those graphs are strikingly different, because we have plateaued and now are rising. They, as you say, are decreasing. So it's a number of things. I think it's multifactorial. It gets back to the concept we've talked about testing, that strategy of testing and contact tracing. I think it has a lot to do with leadership, quite frankly, and nations in the European Union that were able to really comply and have strong leadership and direction. Our country has really struggled and had very uneven response, I think, and been very dependent on local leadership and policies. And we have seen a lot of different approaches in different states, and even in different communities and counties within states. So we are seeing the effects of that. I think there was a lot of skepticism, a lot of very rapid reopening. And one thing that I think we have not done well is related to what we just talked about around schools, and that is reopening in a new way. Some organizations have done a great job of this, some communities have as well, but we've seen quite a few communities, and including entire states, that have really rushed to reopen and treated it more like a switch, so that you're either at home or now you're back, rather than really emphasizing the public health messages of, okay, we can reopen, we must reopen for economic reasons, but here's how we can do that safely. So.
Well, you know, we're hearing, this is not scientific, so I ask for your guidance on this. We're hearing about an expected second wave and rising infection rates across the US. And is it really a second wave, or is it just a slope that we just decided to intersect at a particular time? So talk about what the data is suggesting and telling us right now in terms of COVID-19.
Right. So unfortunately, as those graphs show us, the discussion about the second wave, I think, was started quite early when we were first fighting the pandemic and recognizing that history tells us that prior pandemics have had second waves. And so you always have to remain vigilant about that. And that when a pandemic starts, as this one did early in the year, that we know that when the fall comes around and all the rest of the respiratory viruses start circulating, that we would be at risk for having a second wave that might even be bigger than the first. Unfortunately, for the reasons we've discussed today, our country is still in the first wave. I don't think we have gotten that under control yet. We're seeing sort of the first wave moving across the country and moving into areas that were not as strongly affected at the beginning and now are really getting the brunt of it. We have seen isolated areas of success like New York, even here in Maryland, our graph really looks beautiful. But so in those areas, I think that we can talk about the second wave situation, but as a country, we're still firmly in the first.
And in our region in particular, and I know this has happened in New York and other places, even in Washington State, the density, the communal living and long-term care in Allegheny County, where we're from, right at the beginning, it was about 75%. And even in one county next door to us was 78% were people who were in long-term living communal environments, so nursing homes and long-term care. Are we seeing any change now in terms of any of those trends?
So unfortunately, what I think we saw was that the virus hit early and hit hard in those settings. Long-term care facilities were just inundated with a number of cases, and unfortunately, so many people who died. Many of the nursing home long-term care facility investigations have shown us a large number of mildly symptomatic or even asymptomatic carriers amongst the residents in those facilities as well as the staff. So it just swept through. Other vulnerable populations include prisons, where there have been a lot of infections, and then persons experiencing homelessness and communities in which the housing conditions tend to be more crowded, and it's difficult for people who get the infection to really quarantine away from others. And so it tends to really sweep through those types of settings.
So, we're at our 31-minute mark here, and listen, we could stay as long as we have your attention, which is pretty amazing. Is there anything to be optimistic about?
Absolutely. I'm always an optimist. And I think if we look to countries like South Korea, like Germany, if we look to states like New York and Maryland and others that have had some success, then we see that we can do this. It really takes patience, perseverance, and attention to detail. It's going to take doing things differently than we have in the past. But I really just think that, so I'm very optimistic from that standpoint that this is doable. Mm-hmm. It's going to take leadership, and it's going to take us really getting people's attention on messages that are very clear and trying to help them do the right thing. New Zealand is another country I would point to that has done an amazing job. So this can be done. We can do it. We're just not doing a great job right now as a country, unfortunately.
We're not. So we've got to do better, and we've got to take your advice, and we've got to also, you have a whole bunch of data that is accessible, and we'll put the link out on our site so that people, if you don't know about the Johns Hopkins data set and all the analysis they're doing and the dynamic information that they share, we'll put that out there and we stay on top of that. Is there any other information that you think that you really want to leave us with? And you don't need to be so soft with us, because we need to hear some hard facts.
You need the hard truth, man. Do it. We're ready.
Well, I'm sure that each of you, I think I've said this before, I'm sure each of you is involved in some way in decisions about reopening. And, I do think that this is a time, I am generally, as I said, optimistic. And I think it's a time to really rethink how we do a lot of things. My research, my career is in infection prevention. I think if we learn the lessons that are apparent during this pandemic and take the right steps, that we will prevent other types of infections. You know, there is an argument to be made that if we do the right thing for the pandemic, for COVID-19, we may actually be able to have a very small flu season this year as well. And so what I would love to see is us, you know, really take some of the innovative things that have come, like in healthcare, it's telemedicine. We're trying to figure out how we can utilize that for infection prevention, but also for efficiency and convenience and patient experience. So I think there's some good things that can come out of this, and maybe you know, telework is going to be one of those things, reducing the need for office footprints that are as big as we have them. So I think businesses really should take a look at what opportunities are here and how we can all be safer, but also maybe more efficient and more innovative in the future.
Listen, Dr. Maragakis, you have been more than generous with your time with us. You've given us some great information. We're going to keep track of you, if that's okay, because here in the tech community, we deeply care about all the things that you're talking about, and the partnership with Hopkins and Highmark and AHN is very exciting for us here in the community. We have deep relationships with the leadership there, and Hopkins having a little shingle here in Pittsburgh and partnering with the Cancer Institute and moving forward is a big deal for us in Pittsburgh. And we wouldn't have had you on the show if it weren't for our friends over there at Highmark and Allegheny Health Network. So we thank them and we give them virtual hugs. But we will take your advice. There were some questions here that we'll see if maybe we can shoot them over to you and get some answers to them. That would be great. And we'd love to have you back on. I can't believe that it's been 15, 16 weeks. And we're hoping that there isn't that second wave and that upward incline that you talked about before. But I hope that you will stay connected to us in terms of the work that you're doing. We're a big champion of you, and being bold and being out there and reminding us that it is going to take a paradigm shift that we perhaps have not even embraced today, 15, 16 weeks later. So I can't thank you enough. We're going to keep track of you. I know that you're making your rounds and appreciate making time for Pittsburgh. We're mighty and proud here, and we do like to kick butt, and we're going to continue to do that. So I thank you all. Thank you to our friends at AHN and Highmark for making this possible. And thank you, Dr. Maragakis, for joining us today.
Thank you very much. I'd love to see all of you in person sometime. So stay safe, and thanks for the invitation.
Absolutely. Thanks, everyone. And come back tomorrow, same time.